Simon.
Thank you very much for the invite, though having heard Tim's talk, I'm not sure I'm any longer qualified to give this talk. When I started preparing this talk, I thought this could be really depressing, talking about complications and so on. And I reminded myself, by looking at some of the literature, that actually the artificial urinary sphincter is a brilliant bit of kit. It is highly effective at treating stress urinary incontinence. 3 papers there, big series with up to 100% less than £1 per day for post-prostatectomy incontinence. Susie Venn's series, which is actually Tony Mundy's series from 2000. 100 consecutive patients, 84% dry at 10 years. And then back in prehistory, when I was Tim Stevenson's registrar, I surveyed his cases up to 10, 15 years out. And these were cases going back to the very early days. And 75% of those patients were still continent with their sphincter working, or they'd died of something else. But of course, that is at a cost of revision surgery and problems. And of Tony's 84 that were functioning at 10 years, only 36 had the original implant in. 27 had been revised for mechanical failure, 21 for infection and erosion. And likewise, the Van der Aar summary of 12 series gives some figures for 5-year complication rates. So highly effective, but at the cost of revision surgery. The graph there is from the Sheffield series, which is mostly neuropathic bladder neck slings, cuffs rather, from David Thomas, Paul Tophill, and just makes the point the median survival of these devices is about 10 years. As mentioned on the previous slide, there's really the 3 modes of failure for artificial sphincter. There's infection and erosion, which we tend with sphincters to link together, because usually if you've got an infection, you also have an erosion. That's not universally the case, but this is certainly different from the penile prostheses. Whether that's chicken and egg or egg and chicken is often difficult to work out, or impossible to work out. There's also the mechanical failures and the urethral atrophy, which I've put in inverted commas, which I'll explain later. What I'm going to do is talk about bulbar artificial sphincters first, and then talk a little bit at the end about the bladder necks and the female sphincters. So, erosion infection in bulbar artificial urinary sphincters presents, as you'd expect, with pain, swelling around the pump, redness, UTI, fever. The risk factors are listed there, as again you might expect. The big one for us is previous radiotherapy. Also, cardiovascular disease can contribute. Catheterization, intermittent self-catheterization through a bulbar cuff is not great, but the big catheterization problem is your overzealous orthopedic SHO with a 16 French catheter and no clue about the artificial sphincter. That's a big cause of loss of sphincters. Previous revision surgery is a risk factor. Bladder neck urethral surgery is, and actually having a bladder neck cuff or being female is also a risk factor. So once you have an infected or eroded bulbar cuff, what can you do? Well, there's 2 routes really. There's the conventional take it out, put it back in approach, which is the standard and is what I think the vast majority of people will do in the vast majority of cases. And as you can see from those 2 papers there, you can restore pretty good continence and get a good final outcome, but you do have a 3 to 6 month period in between when they're obviously gone back to being wet. And there's no doubt that your first attempt is always the best, the most durable, 76% to 5 years, whereas the second one's more increased risk of erosion, etc., so 68 to 5 years. Unlike the penile prostheses, there is not a big literature about irrigating with antibiotics and replacing sphincters. I think that is because of the combination with erosion, and I personally would say it's quite difficult to be always certain whether there is an erosion or not. usually it's fairly obvious, but I've certainly seen cases where I wondered whether there was an erosion. By the time I'd taken the cuff out, there was definitely a hole in the urethra. And I'm not quite sure how they selected their 8 patients with 9 procedures in this study, but in a very carefully selected group, I guess this works. The next problem is mechanical failure. Mechanical failure these days is usually leakage of the fluid from either the cuff or the balloon, usually the cuff. Usually presents with a gradual or sudden onset of recurrent incontinence any time after implantation. On examination, it's fairly obvious that the pump's empty or it doesn't fill very quickly. There isn't any infection and there's stress incontinence. You can confirm that it's emptied by either a plain X-ray, if you've got contrast in the balloon, or an ultrasound if you haven't. And as I said, it's usually due to leakage from the cuff. You do occasionally get cases where there's a mechanical failure for other reasons. Tube kinking's gone out a long time ago with anti-kink tubing. You shouldn't be getting air bubbles in if you're doing it properly, if you're doing enough cases. There's a fellow speaker and I have both shared the experience of a cuff either not being clipped properly, possibly, or coming undone subsequently. He was fortunate and he sorted his out. I was unfortunate in that mine got himself referred to Tony Mundy, who then wrote to me explaining how to do the operation. Pumps get displaced, so there's mechanical problems. What to do? Well, you have to explore it and replace. We've just heard that the advice is probably to replace everything. That's not always practical, and it's a surgeon's choice really, whether you just replace the component or the whole thing, but there is a good argument to replace the whole thing based on biofilms. Continence should be about equivalent, but again, there's an increased risk of infection once you've been back in. Urethral atrophy. Again, this is in inverted commas because it probably isn't actually atrophy. When you take a cuff out and find that the urethra is tight and that the cuff is no longer able to interact with it, Tony Mundy reliably tells me that if you divide that fibrous capsule, the urethra springs back to life. So it's probably a fibrous capsule rather than actual atrophy. Presentation, examination, as you'd expect, investigation is very straightforward. You are, however, left with a choice, quite a wide choice of treatments, which I'll run through. You could increase the system pressure, you could downsize the cuff, you can try and augment the urethra, you can go for a sling as well as a separate additional procedure, put in a second cuff, or put a cuff through the corpora. Increasing the pressure seems quite attractive. We generally use 61 to 70 centimetre of water balloons, and you could just simply go back and upsize the balloon. A couple of words of caution about that. The balloons are only calibrated within those ranges. So you could take a patient back to theatre, take out a 70 centimetre of water balloon and replace it with a 71 centimetre water balloon, which clearly isn't going to do much good. We also know that at higher pressures, there is a higher erosion risk. The proponents of doing this would say, well, yes, but you have a reduced risk of causing problems with infection at the cuff site, and that maybe balances out. I wasn't able to find any literature at all about this. Downsizing the cuff, you usually use a 4.5, so you can go down to a 4 quite easily. There is a 3.5 available now, but I think most people would agree that is too tight, and again, the risk of erosion is increased. Augmenting the urethra you can do in a couple of ways. There's one quite nice paper there about putting the cuff outside the BAUS15 AUS, and they seem to have reasonably good results, but it's only short term. This is something I actually did for a few years fairly early on in my consultant career, thinking that this was a good idea. Unfortunately, this is where you do get atrophy under the cuff, because 2 or 3 years later the BAUS15 AUS is completely shredded and you're back to the same situation. So I don't do that anymore. The alternative is to use some sort of collagen mesh to wrap the urethra. Again, I don't have personal experience. These 2 papers, fairly short follow-ups, and certainly the second one would kind of support my own personal prejudice of putting in more artificial material, you're going to get more infection and erosion and problems. So probably not a recommendation. This is another interesting approach. This group had 19 patients who had significant recurrent stress incontinence. And rather than doing anything to the sphincter apart from deactivating it, they put in an advanced sling through separate incisions well away from the sphincter. So they're not interfering with the sphincter's biofilm at all. And they get very good results. 15 patients dry, 4 pretty much dry. And half of the patients didn't actually need their sphincter reactivating, so presumably the sling is doing everything. One slight caveat is I'm not aware of what the voiding function was, so I don't know that all patients had a suprapubic catheter after this procedure, or they're all voiding normally. But it does seem to be logical to me to not be interfering with the sphincter, so you don't interfere with that biofilm and risk infection. Another approach, of course, is the double cuff. This has been popularized by some enthusiasts in the States and elsewhere as a way of getting more bang for your buck, as they say, and increasing urethral closure. And as a primary operation, it was popular for a while, but has diminished in popularity because, as you might expect as a simpleton like me, if you put 2 cuffs in, you've got a greater, maybe ×2 chance of a cuff erosion. You've also got more mechanical problems. But as a salvage maneuver, this has got some merit, probably. And there's several theories talking about adding a second cuff as a maneuver when you've got atrophy and recurrent stress incontinence. Mixed results, really. Very difficult to know whether this is a good thing to do or not. Again, on a personal level, I've done this several times, and almost always I've regretted it because subsequently they've gone on to get an infection. Whether that's just numbers and luck, I don't know. The other salvage type maneuver is to go transcorporally, so you get a bigger bulk of tissue around your urethra. Basically, as you go more distally down the urethra, as you've used up the suitable sites in the bulb with your previous implantations, and you'll find that the urethra is too narrow to accept a 4 centimetre cuff. You could put a 3.5 in, but as discussed earlier, that's possibly a higher risk of erosion and infection anyway. So you go via the corpora and incorporate more tissue and get a bigger cuff in. And this is quite a straightforward thing to do. You worry about erectile function, but these patients rarely have good erectile function anyway. You worry about bleeding, but if they haven't got good erectile function, they're not likely to bleed very much. And it's a fairly straightforward thing to do. And again, results with this maneuver in these 2 papers certainly are reasonably good, though short-term follow-up again. So moving on to the neuropaths and the bladder neck membranous slings, obviously mechanical failure is the same. Urethral atrophy doesn't occur because of the bulk of tissue within the cuff, so you're left with the infection erosion problem. It does seem to be commoner, possibly because of the nature of the patients in terms of general morbidity, neuropaths with sores and chronic sepsis and so on. Possibly, some people say, because of an associated sisterplasti, possibly because of the intermittent catheterization. The other thing is that these are young patients, and if the half-life is 10 years, they will eventually erode just because they're going to have the thing in there for so long. Management is as before, really. You need to remove the device. One useful thing that I have picked up from Simon Harrison is when removing one of these, is take a strip of rectus fascia as you're going in and suture it onto the tab, and then as you're removing the device, it wraps around the urethra, and you can secure it as a sling under gentle tension. And that does 2 things. It offers a bit of resistance, but also it shows you the route to go back in if you need to in future. And quite often you don't need to, because their continence is restored by that maneuver. On the subject of the sisterplasti, this again is graphs from the Sheffield series, and on the right there's the one about sisterplasties demonstrating that there is no difference, significant difference in infection rate, whether you've done an artificial sphincter at the time of a sisterplasti or as a separate entity. And slightly surprisingly, the other graph suggests that those patients in their series who aren't doing intermittent self-catheterization possibly have a higher risk of sphincter loss than those that are doing it. Females. Female AUS, we just heard, I think, 6 in the UK a few years ago. Not at all popular in this country, but as you'll see on the left of that slide, some very respectable large series from elsewhere in the world. And this is a good option for failed stress urinary incontinence surgery in females, sometimes for neuropaths, sometimes for pelvic fractures. Again, at a cost. There is a higher risk of infection erosion, presumably because of where the cuff is going into a very narrow space where frequently there's been a lot of damage. I like to describe this operation as surgical archaeology, because you're digging your way through the colposuspension, the TVT, the macroplastique that's all there before you. And you do get a higher risk of infection. But again, you manage them as for the bladder neck ones, put in that fascial sling, and very often they remain continent. So finally, in conclusion, the most important thing to remember from this talk is that the artificial urinary sphincter is a highly effective, excellent treatment for all forms of stress urinary incontinence. And often there is no option to putting one in, apart from persisting incontinence. 3 forms of failure, which I've discussed. Diagnosis is pretty straightforward, and really the salvage manoeuvres, the surgical manoeuvres to treat those forms of failure are as listed. Quite a lot of question marks. But that's the nature of this specialty. But usually there is something you can do. Usually you will be able to get another sphincter in. Continence will be restored to a reasonable level. However, there is always an increased risk of further infection. Thank you.
Thank you very much, Simon. Have we got any questions for Simon? Just one question. Do you think we're underutilising AUSs in this country? Because I know we definitely do that for penile prosthesis.
Underutilised, definitely. If you think that 8 to 10% of people who have radical prostatectomies in all respectable series have significant incontinence, and I can't remember the figure Tim showed us, but that's certainly not 8 to 10% of radical prostatectomies. And I think also in female salvage incontinence, we drastically underuse them currently.
Well, I mean, the outcome data looks very good, so I think we should be encouraging people to refer on to specialist centres that can offer AUS. Okay, thank you very much.
Thank you.